Okay, sorry for that delay. We were having some small technical difficulties here. So today we're going to be talking about the chronic leukemia, so CML and CLL cases. I know Albany is on a delayed start. They were sent Zoom connections, so thank you to those of you who have been able to Zoom in. But we're just going to jump right into case number 1. There's no quiz today, so don't worry about that. So the first case is PS, it's a 73-year-old female with newly diagnosed cancer. The bone marrow biopsy is a hypercellular, and there's an abnormal of the translocation 922. FISH or fluorescence in situ hybridization is also positive for the translocation 922, and a PCR of quantum.
Dr. Clemens?
Yes. Yes.
I'm sorry, we just couldn't hear you, but I think we'll try to fix it on this side. Oh, and also we cannot see the slides.
There are no slides.
Okay, thank you.
No problem. There's a Word blank case document posted to ELC for you all to take notes on as you go or with your groups, but they're not on like a PowerPoint slide. It's a Word document. Is the audio better for y'all?
Still working on it.
Okay. I'll give you guys just a second.
And Dr. Clemens, since you said there's a Word doc, we can't see that either. I'm not sure if you wanted us to be able to see it, but we can't.
I'm not projecting anything. It's posted for you all just to take notes on as you go. So the blank, like the cases without answers is posted to ELC. So you can fill it in as we go, but I don't project anything for the cases. I turned up our mic volume, or Ronald did that help? Or
yeah, it helps. We're good.
thank you. So case 1 is a 73-year-old female with newly diagnosed cancer, positive for the translocation 922. So based on this general information, group number 2, what type of cancer do you know that this patient has based on their workup results?
CML.
Good. So that is a translocation that I think is important that everyone knows. So again, your translocation for CML and APL are the only 2 specific genetic markers I think are necessary to memorize. So I'm going to tell you that this patient's in chronic phase. As I mentioned in the pre-class lecture, accelerated phase and blast crises are a lot less common. Most of you won't be seeing it in clinical practice. So I really wanted to focus on the disease state that's much more common, as well as that which translates the majority into the ambulatory community setting. So group 2, what are the signs and symptoms of chronic myeloid leukemia that you would associate with a patient on a presentation of new diagnosis?
Most patients present asymptomatic, and then it's just general fatigue and weight loss.
Good. So about 50% of patients with CML are diagnosed incidentally on routine labs. So older patients that go to their primary care physician and have, a routine physical or labs and workup, they may notice the laboratory abnormalities that way and then dig further into the bone marrow and get the diagnosis. But of the 50% that are symptomatic, it can be those general symptoms. So fatigue and malaise are pretty non-specific. What other slightly more specific and related to the disease process signs or symptoms would you associate? And anyone can answer that.
They could have left upper quadrant pain, or satiety, or abdominal symptoms, spleen, or hepatomegaly.
Good. So kind of the spilling of all of these chronic myeloid cells from the bone marrow into the peripheral blood, they can kind of get sludged in the spleen and the liver. So those organs kind of filter our blood so that we can have enlargement in those organs as all these cells kind of go through. And early satiety and abdominal distension kind of come from that hepatosplenomegaly. As the organs get bigger and they crowd out other things, you can have some symptoms from those signs. Excellent. And so let's go to group 24 for the next question. What are the initial treatment options for CML? So what are the drugs, their doses, and kind of in general, how does this category of medication work?
We said you have to categorize it based on if they're low, intermediate, or high risk. And that's based on their age, spleen size, platelet count, and blast cell count. So the options are imatinib, 400 milligrams by mouth once daily, dasatinib, 100 milligrams by mouth once daily, nilotinib, 300 milligrams by mouth twice daily, and bosutinib, 400 milligrams by mouth once a day. And these are the tyrosine kinase inhibitors.
Excellent. So 2 follow-ups to that in the same group. How do the TKIs specifically work? And if you're low risk or high risk, is there any difference in the recommendations for which drugs to use or not use?
If it's high risk, you can use anything but imatinib, and then 1 second on the mechanism. They block activation of the BCR-ABL tyrosine kinase,
What does that
which
mean?
stops.
Oh, sorry, go ahead.
We said
So by blocking the BCR-ABL tyrosine kinase, what does that lead to?
allows apoptosis.
It does. So thinking about kind of the pathophysiology of CML, you have this mutant tyrosine kinase. So this is an enzyme, that now is constitutively active. So it's always telling the cell, divide, grow, keep going. And that's abnormal, right? We have normal cell cycles that are supposed to not allow for overproliferation of any particular lineage. But the BCR-ABL tyrosine kinase is always active. So it's always telling those cells to continue to replicate and divide, and that's not normal. So because it off the abnormal signal, it allows the normal intracellular processes to go on to allow the cell to undergo apoptosis and not continue to divide and grow. So it kind of stops that overgrowth specifically. So in this case, this is a disease with a very specific genetic mutation that we can target with a very specific drug. In the pre-class lecture, I talked a little bit about how imatinib was hailed as a potential cure for cancer. Well, a cure for the specific type of cancer that it can target, right? So it was one of the first targeted therapies to hit the market, but it only is applicable in diseases that have this very specific mutation. So we're talking about it here in CML, but in the leukemia lecture we did talk, or acute leukemia lecture, we talked a little bit about it with Philadelphia positive ALL. So there are other diseases that can have this particular mutation, but CML is the most common and the hallmark where the drug was originally kind of developed. But this mutation can happen in acute lymphocytic leukemia as well, and that is the Philadelphia positive ALL. The drug doses, side effects, it's all the same. But I, for consistency's sake, chose to teach it in this class, but I alluded to it in the acute leukemia lecture as well. Any questions on how the TKIs work? Okay. I don't test on doses of drugs. I'm not going to have different answers that already know the different doses. That's something I feel like you can always look up. I do want to comment that some of the TKIs, there's different literature about different doses, so these are the guideline recommendations, but there are a few alternatives for imatinib and dasatinib specifically. I don't have the time to get into that kind of data in class, but for those of you who may work in a community or a specialty pharmacy and dispense these, there are some other options. There is data for that. We just aren't going to get to that granular level today. I just wanted you to recognize that they're oral drugs, and more the drug interactions and side effects are the more testable information, as we'll get to shortly. So PS comes back to clinic in 2 years for a repeat visit, and the BCR-ABL PCR shows an increase in the level. So workup of the patient reveals a resistance to imatinib due to a mutation, and she is currently, that's the drug therapy she's on. So let's go to group 20. What are the treatment options now for this patient, and what are the main side effects of each of those drugs?
The imatinib and taxane, and the side effects are hepatotoxicity and cardiotoxicity for the imatinib, and for the taxane, thrombocytopenia, anemia, neutropenia, and grade 3 or 4 myelosuppression.
Okay, so with imatinib and omalizumab, what is their specific indication? 3 lines of therapy once someone has failed.
Is there a third line?
Right, so for this particular patient, she was on imatinib and has a resistance to that. That would only be 1 line of therapy. So these 2 drugs would not be indicated yet. And if that were her 2nd line therapy, she had failed, or she had failed the subsequent therapy after imatinib, then those 2 could potentially be options. But at this point, they would not be the best options, A, because they're not indicated that early. And the reason they're not indicated that early is the side effects you just listed, which are accurate. Homocysteine has a significant incidence of grade 3 and 4 myelosuppression, so it would be very difficult to tolerate for patients. And the ponatinib, as you discussed, there are some cardiovascular complications that can be severe, even fatal. And so that is a drug where you really only use it when the benefit is going to outweigh that significant risk. While the incidence of those is not very high, because of death, obviously we care more. So those are more 3rd and beyond line. So what would be more 2nd line options?
The other TKIs like bosutinib, which has ADRs of diarrhea, thrombocytopenia, and increased LFTs, and the nilotinib, which has adverse effects of QTc prolongation, elevations in lipase and amylase, bilirubin and LFT elevations, and
The statin? The pronunciation is the statin, is that what you're?
bosutinib. Dasatinib, nilotinib, and bosutinib.
Right, good. So the first line, as we just discussed, can be imatinib, dasatinib, nilotinib, or bosutinib, with imatinib not being the preference if you have high-risk disease. And then second line, if any of those, obviously other than the one you started on and have already failed or were intolerant to or resistant to, of course. So if this patient was on imatinib and that's off the table, the other 3 are all options. And as you said, bosutinib has specific side effects, mostly of GI, myelosuppression, and increased LFTs. The nilotinib has a lot of lab abnormalities to consider with amylase and lipase and hepatotoxicity, as well as the need to monitor for QT prolongation. And then dasatinib has issues with pleural and pericardial effusions, which is very specific to that drug. You can have some myelosuppression, GI effects, rash, edema, headache, and fatigue. So some general kind of constitutional symptoms as well. So how would you pick a 2nd line setting between those 3? They're all category 1 in the guidelines. So how would you decide? A lot of it is based on the side effect profile and your patient's comorbidities are. So if I told you this patient, was post-transplant and had a lot of diarrhea, you're probably not going to pick a drug that also exacerbates that. Or if they have irritable bowel syndrome, you wouldn't want to pick that. If they're already struggling with low counts because of their disease state, that's not necessarily a contraindication to something with low counts, because the low counts are going to resolve with effective treatment. So that's one caveat I just want to try to point out about heme malignancies, is that low counts are due to the disease. So fixing the disease will fix the low counts. So it's okay to add a drug that causes low counts. Patients have to monitor for it. That would not be a contraindication. But obviously somebody with hepatitis that was active, you want to pick something that causes increases in your LFTs and bilirubin. If somebody's already on something drugs that prolong QT, you want to avoid nilotinib. Things like that. So there isn't an exact, you have to use this drug over that drug. You have to look at the patient's comorbidities, their other drugs for interactions, and try to pick the one that's going to cause the least impact on what else is going on. Remember, these drugs are very long term, so this problem and issue with drug interactions and side effects is going to be a long-term issue. And so for 20, since you already kind of stole the show here with some other information, the next part is if the patient fails your 2nd line therapy, now is on 3rd line. And specifically, the mutational analysis shows the T315I. At this point, for 3rd line therapy, what are the 2 drugs and other interventional options? Just refresh us what you've kind of already told us.
Ponatinib with 30 to 45 milligrams PO daily with or without food, adverse events, hepatotoxicity, cardiotoxicity, homocysteine, grade 3 or 4 myelosuppression, thrombocytopenia, anemia, and neutropenia.
Good. So those 2 drugs are definitely 3rd line and beyond. Again, they're difficult to tolerate. Remember that olmesitaxine does cause a significant myelosuppression, and also it's a sub-Q drug, it's not an oral drug. Technically, you're supposed to administer it in a healthcare facility. Well, it's Q12 for how many weeks and then off, and then the maintenance phase. So the logistics of doing that for patient care, coming into a clinic twice a day or an infusion area, is very, cumbersome from the patient perspective. I've used it a few times in a few patients. To be honest, several of them have been in the prison system, so it's easy because their transportation is arranged for them, so we don't have to worry about the logistics. But we try to only use that drug if we absolutely have to because of the logistics and the myelosuppression. Can be very difficult to tolerate. The ponatinib also can be difficult to tolerate in my experience. The labeled indication, as you just said, is a dosing of 30 to 45. I've had plenty of patients who have the dose reduced for these side effects, specifically the hepatotoxicity I've encountered multiple times. Thankfully, I haven't seen anyone with the cardiovascular complications, but we do have to counsel them on it and have to be aware of the significant cardiovascular, cerebrovascular, and peripheral vascular events, including heart failure and death. So this is not an insignificant adverse reaction that patients need to be aware of if they start this therapy. Other than those two drugs, what else can we do for patients who have failed multiple lines of a TKI? What then are they eligible to receive as a therapy to potentially even cure their disease? Does anybody remember that?
Transplant.
Right, so an allogeneic transplant. We're going to talk about that, I believe, next Friday is the session for that. So chronic myeloid leukemia, because we have good drugs and we can treat people for a long time, and technically it's incurable with standard therapy. If they fail multiple lines of therapy, they are eligible for an allogeneic transplant. We don't do that up front because CML is mostly older patients who can't tolerate a transplant. But if they failed all of our other options, we would move to a transplant if they could get it. And the other thing is a clinical trial. So the National Comprehensive Cancer Network always recommends a clinical trial as an option for patients, and especially in subsequent lines of therapy where we don't have great options. So that's something that we always do bring up with our patients to see if they're interested in. But remember, ponatinib and olmesitaxine are not first or second line and associated with some significant side effects you should be aware of. Good. So any other questions? We're going to move on to case number 2. Okay, group 10, we're going to talk about patient SS. This is a newly diagnosed chronic phase CML. She has obesity, sleep apnea, she's had a TIA, she has diabetes, hypertension, heart failure, osteoarthritis, and GERD, and she's a former smoker. I've given you her current medications like aspirin, metformin, metoprolol, lisinopril, Lasix, spironolactone, potassium, esomeprazole, tramadol, PRN. I've shown you her blood counts and her chemistries, and here it's a real patient, actually somewhat simplified her a little bit. We'll just write on her chart exactly. And this is talking about initial and then subsequent therapy. So group 10, what's the most appropriate initial therapy? Thinking about this patient's other factors. And I did not give you, we'll say she's low risk. I didn't type that in there, but let's say she's low risk for the purpose of this discussion.
So for SS, you want to assess whether the patient needs to be on the PPI, and then the most appropriate agent at the moment would be imatinib, because it doesn't interact with PPI and also doesn't interact with the other medication she's taking.
Good. So definitely picking up on the drug interactions is the main focus here. And this comes up quite a bit because, as we all know, PPIs are pretty commonly prescribed. And so she does have that history of GERD, but I like how you said, let's find out if she really needs it. How long has she been treated? Can we trial her off and see how she does first? What would be your option as an alternative to the esomeprazole if she needed something but was willing to try a different agent to treat her GERD, to be clear?
H2RA.
Yeah, so that's definitely kind of part of the role of our system to decide is can we modify the easier therapy to modify rather than the cancer treatment. And so let's say this patient had severe GERD and definitely does not want to, the physician doesn't want to change. And so we're going to have to keep that PPI. I do think that imatinib is a great choice. What will be one of the side effects of imatinib we would need to specifically monitor in this patient, group 10, because of the comorbidities the patient has?
Probably going to be the edema.
Good. So because the patient has heart failure and imatinib can cause edema, we want to monitor for that. Make sure we definitely counsel the patient to keep track if that's somebody who's doing daily weights at home and potentially needs more diuretic or anything like that. So we would need to monitor that very closely. Now, the other drugs, let's say the patient was able to come off their esomeprazole, was able to switch things, then we still have some options. It's just something to think about, right? So if the patient were able to go on an H2 blocker like famotidine, bosutinib would still be an option, but we would need to monitor for those other side effects we already discussed. So thinking about the patient's blood counts, their LFTs, any diarrhea, but bosutinib with an H2 blocker is acceptable. That would be a potential choice. Dasatinib is not, supposed to be utilized if you're on an antacid, so we would want to avoid that in this particular patient. So I agree that's not the best option. And then nilotinib we have to think about in this patient. They're hypokalemic, right? Potassium of 3.1, and that would put the patient at further risk of QT prolongation. So if the patient's on diuretics and on potassium and isn't stable, or it looks like they aren't being well managed from that aspect, then we would want to put them at increased risk of QT prolongation if we see that their electrolytes aren't normal, or some patients with heart failure are very stable and they can keep them managed pretty evenly. But if this is someone who is not evenly managed or easily managed, then we want to avoid that, because that would put you at increased risk of QT prolongation. But again, if it's a well-managed patient and you can keep up with their electrolytes, then you're less worried about the QT prolongation. So I didn't give you all of that in this case, but that's the kind of stuff you have to think about, talk to the patients, look back at their historical labs and drug bills for how are they doing with their heart failure management, how well are they managed. A patient who's non-compliant, doesn't come to clinic, doesn't do their weights, doesn't give their Lasix at home, then you'd be a little more worried than someone who is very compliant with their medicines, their visits, their labs seem pretty stable chronically. So just because there is an interaction or a potential issue and you can't use a drug, you have to make it very patient-specific, make sure that you're making it the safest choice. So in this case, imatinib will be the best answer. Nilotinib and bosutinib are options as long as you manage the patient comprehensively, appropriately. So group 10, you're doing a great job, so we're going to keep with you for the next part of this case. So 2 years later, this patient is on lymphoid lineage blast crisis based on the rising B-serial transcripts on the bone marrow biopsy. She's admitted to the inpatient unit where you're going to take over her care. So at this point, being more in a blast crisis diagnosis, what type of treatments would you anticipate this patient receiving?
We would do a TKI plus or minus induction of chemotherapy with an allogeneic transplant if eligible.
Good. Based on being in a lymphoid lineage, is there any additional therapy this patient is indicated for?
LP lineage to test CNS disease.
Right, so this patient would need a spinal tap to look for disease in the CNS system. Sorry, I can't talk today. And that's because, remember, your lymphoid lineage is much more likely to feed into the CNS. So when we did acute leukemias, acute myeloid leukemia very rarely goes into the CNS. It can happen, but it's not common. Versus your ALL, your lymphoid lineage, is definitely going to get into the CNS if you don't provide prophylaxis. So if you have someone with chronic leukemia that's of a lymphoid lineage, you still have to worry about that CNS seeding, because those cells are just physiologically are more likely to get into the CNS. And so if you have somebody in the lymphoid lineage, you have to assess for CNS disease and consider giving prophylaxis and treatment of that CNS seeding if it's there. Versus if you had just a myeloid lineage involvement as you go into blast crisis, then you're less worried about it. Just like you're less worried about it with AML, only if they have symptoms. But if it's a lymphoid lineage, you should always be thinking CNS, and asking for that. And that could definitely be a good catch for the inpatient pharmacist to say, hey, based on the lineage, do we need to get that spinal tap? I'm like, oh yeah, we definitely need to do that. So that's something that can really help get therapy started earlier for patients who need it. As you said, TKIs are still our mainstay. Patients who are eligible, again, they have to be young enough, fit enough, not have any comorbidities or organ dysfunction that excludes them from intensive chemo. But they're going to get chemotherapy just like the acute leukemias get. Blast crisis basically looks like an acute leukemia. Some patients who present in blast crisis, we think they have an acute leukemia when they walk in the door, and then only on the subsequent evaluation do they get reclassified as a CML blast crisis. So because it's a lymphoid lineage, would be treated more like an ALL, versus if I told you this patient was a myeloid lineage, they would get treated more like an AML. So because this patient's lymphoid lineage, it might be more like a TKI with hyper CVAD, versus if it was myeloid, it would be a TKI plus 7 plus 3. So it would depend on their lineage, which chemo they get. But again, if they're very old, aren't physically fit, they may not be eligible for that. They definitely wouldn't be eligible for the transplant. But if they're young enough and fit enough and they get the chemo, they get into a remission, so they get back into chronic phase, then we can take them onto the transplant at that point. And if they don't, then they typically go to hospice, because if this disease is not controlled with initial induction, they really don't have many options other than a clinical trial. Great, so let's move to group 16. So if SS does get back into the chronic phase, is she eligible to discontinue TKI therapy? If so, when? And if not, why?
She would not be eligible to discontinue because she's had it in last time.
Good. So what is the criteria, and what parts of the criteria does someone need to meet to be able to discontinue their TKIs? I should say trial discontinuation.
We have to meet all the criteria.
Yep, so the most important thing is they have to meet all the criteria. You can't just meet some of them, you have to meet all of them. And what is that list of criteria?
They have to have no history of relapse crisis. Have been on the TKI for at least over 3 years. To have the stable response, which they do on the short test, at least 3 months apart. No history of TKI resistance and access to the reliable PCR monitoring to be able to conquer all those checks.
Right, so that checklist in general, I do want you to know. I'm not going to ask you exactly what PCR threshold they have to meet. You can always look that up, that's okay. But you need to know that they can never have had accelerated phase or blast crisis. They can never have had resistance. They have to have access to the reliable monitoring and be compliant with being able to come in for that. And they have to have had a response for at least 2 years and been on a TKI for at least 3 years. So those durations I do think are important to consider. Because as we're counseling patients, they're going to say they've read about this, they've seen it online. When can I stop therapy? And I think it's important to set an expectation in counseling for the minimum duration someone's going to have to be on these therapies, especially because how expensive are these? These are thousands of dollars a month. So for some patients, it's a huge financial hardship to undergo this type of treatment. Even though it's an oral agent they can take at home, so they don't have to necessarily come in as often as patients on IV chemotherapy, it's not a cheaper or more cost-effective route necessarily from a patient or a systems perspective. So I do want you to know these criteria because you are going to get access. It gets some press, it's online, patients do look these things up and want to know. They'll say, I thought I don't have to be treated forever, my doctor said I would. So being able to triage these questions and concerns, I think is very important from the pharmacist, because they're going to ask you what they can do, or they're going to double check what their physician said. That happens all the time. They trust us to kind of know that information. So again, I won't take the nuances out of this, but I want you to know the general list and the durations, because I think that's important. How often they have to be tested and all of that, don't worry about it. I'm not going to test you on that. But this checklist is very important to know. Any questions on that? It is exciting that some patients can stop therapy, but as I mentioned in the pre-class lecture, up to 50% of patients are going to have a molecular relapse and have to be restarted on a TKI. So again, setting expectations in counseling, if someone does trial discontinuation, they have to be compliant with their monitoring, and they have to understand there's about a 50% chance they're going to have to go back on therapy. And at that point, it's considered lifelong therapy. I've not seen any studies doing a second discontinuation. And part of the reason you can't have had accelerated phase blast crisis or resistance is they're less likely to respond to subsequent therapy. So you wouldn't want to trial them off and then them not respond, and it could go downhill pretty quickly from there. So only the most perfect patients are eligible at this time. Maybe in the future we'll do a better job of this. But this really highlights the fact that our molecular testing, even though it's so deep, and we're looking at a million cells and trying to quantify do any of them have the disease process, even if we say no, they don't on repeated testing, there's a cell hiding somewhere that we're not quantifying, right? So even with deep molecular testing, it's not perfect, and that's why people are so relapsing after trialing off. So our tests have gotten better, but we can never test every cell in the whole body, and so that's always going to be a limitation in stopping therapy. Good. Let's go to group 26. We're going to start with case number 3 now. So this is CD, who is a 74-year-old male. He had shingles in 2014. He was diagnosed with CLL Rye stage 0 in 2013. He didn't have any abnormalities chromosomally at that time. Fast forward to 2017, and he came back as a referral to our cancer center with B symptoms. He had 2 nodes involved, but his blood counts were normal. The absolute lymphocyte count had doubled at that time, and the biopsy revealed 28% B cells. So at that point, he was started on ibrutinib therapy. He also, in 2016, had had some cardiac stents and had cardiac ablation, what you see in the consult note in the chart. His medications are the ibrutinib. He takes a baby aspirin. He was recently on Plavix but stopped. He has carvedilol, losartan, a multivitamin, Pepcid, potassium, pravastatin, and Zoloft. And he takes those medications for depression, GERD, hyperlipidemia, AFib, and he's had a history of end-stemming. And he does have CKD as evidenced by his labs with a current creatinine clearance of about 44. He has normal LFTs and IgG of 3 to 35, and I've provided his CBC there for your reference. This, again, is a real patient, which is why he's a little more complex, so he's definitely someone we've seen in our cancer center. So group 26, starting at the beginning, what signs and symptoms would you have expected to see in the note from his initial diagnosis, either in 2013 or 2017 when his disease progressed?
Oh, sorry, our mic was off. So signs at presentation would be fatigue, weight loss, and recurrent infections. She could have splenomegaly, which happens in greater than 50% of patients, and hypogammaglobulinemia, and hyperleukocytosis.
Good. So the hypogammaglobulinemia is the low IgG level. The high white count can be hyperleukocytosis, and then the other signs and symptoms are definitely accurate. So again, some constitutional symptoms that can present similar to CML with the fatigue, but then we also see similarly with the potential for splenomegaly, but recurrent infections and lymphadenopathy are more specific to CLL than CML. Good. So same group, what are B symptoms? So the patient has some B symptoms. What does that mean?
She has fever, night sweats, and weight loss.
Excellent. So knowing what the B symptoms are for this session as well as the lymphoma session is very important. You're going to see that in a lot of charts, and knowing what they are is important. So patients that have these symptoms tend to be a little more symptomatic on presentation. Good. So what cytogenetic results would support or would lead to a poor prognosis for this particular patient? So knowing they have CLL, what are kind of the cytogenetics that are associated with worse outcomes through 26?
11q and 17p deletions, and then the TP53 mutation.
Good. So 11q and 17p are poor prognostic factors. And remember, your TP53 is a tumor suppressor gene. So in any cancer, if you have a mutated TP53, that is not a good thing. That's a universal across any solid heme malignancy, doesn't matter. That's never going to be a good prognostic factor. So not having your tumor suppressor gene is obviously going to be a problem and be a poor prognostic factor. Excellent. So group 13, this patient tells you he's relieved of his blood work results. He says, the ibrutinib is finally working. I'm so happy. What is he probably referring to, and how would you reassure him about this?
So we said lymphocytosis is one of the most common adverse drug reactions, and that the onset is in the first few weeks and duration is usually a few weeks to months, and it indicates response to treatment.
Right, so that lymphocytosis is not progression of disease, right? So that initially the patient had their first few follow-ups and they were told that their lymphocyte count was going up, and they were told that a high lymphocyte count is part of their disease, they're going to think that their disease is getting worse, right? Because that just would make sense. But we know that this drug helps mobilize the lymphocyte cells out of things like the spleen and the lymph nodes into the bloodstream, and then they die off. So it's kind of mobilizing them from the sites of disease into the bloodstream, and then they're pulled off through the mechanism of the drug and filtered out of the body normally. So instead of having high lymphadenopathy and splenomegaly and whatnot, those sites are going to shrink, but the blood count's going to go up transiently, and then it resolves as the drug works. And so because this drug doesn't kill all the cells immediately the way cytotoxic chemo does, there's a time frame that it's going to take for that to happen. So it's this quote-unquote transient lymphocytosis, which isn't that transient. Weeks to months is not really, for patients, a transient thing. For it to go up versus and then go down. And so really it's just redistributing the tumor burden before the bulk of the disease is killed off. So it doesn't indicate disease progression, and we don't stop therapy just because of a rise in lymphocyte count with these drugs. We have to give it time and then reassess later. And that's different than how we assess CLL when we were just giving cytotoxic chemo. If you gave cytotoxic chemo and 3-4 weeks later your lymphocyte count was up, that meant the chemo didn't work. You can't apply that same principle with a different mechanism of action. We had to readjust how we assess this disease state. And I think up front, if you're dispensing ibrutinib, it's very important to tell patients that their lymphocyte count can go up in the first few weeks to months, and that is not a concern about their disease process, that's an anticipated normal finding, and that can put them at ease. Because a lot of times they come in for labs, they go into their little patient chart portal, they call in, and they get results, and then they're worried or freaking out about it. They don't need to, but that's if you can put their mind at ease, and they already can be very anxious about having a cancer diagnosis and starting therapy. So that's a key counseling point in my opinion. So same group, 13. So thinking about the counseling of the patient, what drug interactions should we consider, and what are some other counseling points other than the one we just mentioned?
We said the main interactions were for inhibitors and inducers, so like avoiding grapefruit. Caution if P-lipoprotein substrates are also being used because this drug can increase the absorption and the drug interaction between warfarin.
Okay, you cut out just a little bit, but I think you said CYP3A4 inducers and inhibitors, which is accurate. The PGP substrates interact with those, and I definitely like how you stated to avoid the grapefruit, because that is a particular thing we need to counsel patients on. And then an additional side effect I always say with all oral chemotherapy is never start or stop a medication without consulting with your physician. Because if they have drug interactions that we've already accounted for, the patient may not know that, right? So we prescribe drugs and we do dose adjustments, and it just happens, but they may not know that that's what's happening. So making sure we tell them specifically not to start or stop medications, including over-the-counters, without talking to their doctor, because it may affect the dose and efficacy or safety of their oral chemotherapy. That's a counseling point across the board. I always say to every oral chemo patient. And then the last thing is there any interaction with acid suppressive therapies with ibrutinib?
Could you repeat the question, please?
For ibrutinib, is there any interaction with acid suppressive therapies like PPIs, for example?
No.
Correct. So, in contrast to several of our TKIs where it is a significant concern and can reduce the efficacy of those drugs, fortunately for ibrutinib, there is no interaction. So while this patient's on Pepcid and has a history of GERD, even if he, were to continue to take the Pepcid or switch to a PPI, thankfully we don't have to worry about it. And again, I think it's really important to know what interacts with your acid suppressive therapies with oral chemo, because if it interacts in a way that's going to reduce your exposure to your chemo, it's going to be less efficacious, and that's a significant concern when you're treating these disease states. So always looking that up, particularly if you see a patient on an acid suppressant drug or with a history of GERD, to find out what are they taking, is that acceptable, and if not, make sure the patient knows what they can and can't take. So even though it's not an interaction, that's something you should definitely look at and make sure you're comfortable with each time you see these drugs in patients. Good. So group number 1, what are the main side effects of ibrutinib, other than those that we've obviously just discussed about transient lymphocytosis? So what else would you want to counsel a patient about?
Diarrhea and myelosuppression, which manifests as bleeding, bruising, or infections.
Okay, so what would you want to tell the patient about the diarrhea? Remember, these patients pick up their oral chemotherapy, they go home, they start taking it. So they're in the community setting. When would they kind of need to be, you have to anticipate and counsel them on when they need to triage themselves to call or to come in. So what would kind of be the threshold for that for either of these side effects you just mentioned? Does that make sense?
Possibly if they see blood in their stool or anything above, like 3 or more stools above their baseline.
Good. So for the diarrhea, letting them know that a small amount of diarrhea is normal and not concerning. But if they have significant increase in their stool volume, like you said, 3 or more stools above the baseline is an acceptable threshold. Sometimes we just tell patients a significant change is worrisome to them. Blood in the stool is a definitive need to call the doctor. For the myelosuppression, letting them know that their blood counts may drop, but what does that mean to a patient, right? Because you say your blood counts will drop, they may not know what that means. So what specifically kind of patient-friendly terms would you want to say?
If they develop a fever or chills,
Good. So saying you're at increased risk you could be at increased risk of infection due to alterations of your white blood cell count. If you have a fever, chills, or any sign of an infection, you want to call the doctor and go to the emergency room. And then for the other lineages, if they have bruising or bleeding that is concerning, they should call the doctor. That would be obviously for the anemia and thrombocytopenia. We don't see a whole lot of anemia that causes significant fatigue with this drug, but it wouldn't be inappropriate to comment on that if you're talking about myelosuppression. And then there are a couple of other side effects that we would want to talk about. So any other group have other things you would also add to this list?
The drug can be renally toxic, so I would let the patient know to stay pretty hydrated. And then secondary primary malignancies are common, especially with skin cancers. And I think that's it.
Good. So making sure they're aware they can have second malignancies, typically of the skin, so dermatology referrals. If they notice anything abnormal, they should promptly be seen. Thankfully, those are usually non-melanoma skin cancers that can be easily excised and treated. But making sure the patient's aware to look for that and to have those referrals promptly. And the only last thing I would add is what are the signs and symptoms of atrial fibrillation, since that is also a side effect of ibrutinib. And this patient does have a little bit of a cardiac history, so considering that may worsen, he may already know what that's like, but again, making sure the patient's aware there could be cardiac complications and to report any feeling of abnormal heart rhythm immediately for evaluation. So kind of along that same line, group number 1, it was alluded to earlier, so you know, freebie here. If the patient had AFib or develops AFib and needed to be on anticoagulation, which agent is not recommended in combination?
warfarin.
Right, so the drug interaction with warfarin, we want to pick a different anticoagulation with ibrutinib, and so patients who require that, we pick an alternative agent. And again, if they have AFib or develop AFib, they may need anticoagulation, but we would want to avoid the warfarin product. Excellent. So group number 11, to finish out this case, what supportive care recommendation specific to this patient case with the information I gave you, what other intervention is needed at this time? And not vaccinations, because that's part 2. So hold off on that for a second.
All right, so we're going to go with infection prophylaxis, hydration, and OTC antidiarrheals.
Okay, so if the patient develops diarrhea on ibrutinib and it's non-bloody, non-significant, over-the-counter antidiarrheals can be utilized. Specific for preventing infections, what is the drug that's required and what lab test was the reason that this is indicated?
Sorry, the might be an IgG test.
Excellent. So this patient has an IgG level of 335, which is below the general 400 to 500, depending on your lab threshold for being low. So the hypogammaglobulinemia means you're not producing enough IgG. If you're not producing enough immunoglobulins, you're more immunocompromised, so you're more likely to have infections. So in CLL patients who are hypogammaglobulinemic, we can supplement with external IgG through intravenous immune globulin or IVIG product. IVIG is pooled immune globulins from healthy donors. It is extremely expensive. A few years ago, I was at a talk where it was kind of compared. It was called Liquid Gold, and they compared the price, per volume of IVIG to the price of gold at the time. It was more expensive. So it's definitely not an inexpensive product, but patients who meet the criteria, they do need it, right? So we will give it to them. So this patient with an IgG of 335 meets the threshold to be supplemented with IVIG. So we want to do that to boost them up so that they are more likely able to fight off infections moving forward. So that is an infection prevention measure, even though it's not antibiotic prophylaxis. It's still something that helps prevent infections. Now with this particular case, because this patient is on ibrutinib, general, prophylaxis for like antibacterial prophylaxis is not indicated. We're going to talk about a few other drugs and interventions for CLL that have different mechanisms, and ergo the patients need to be on specific prophylaxis, but for ibrutinib itself, that is not an indication. But the patient's lab level of IgG is the indication to give the supplemental IVIG to resolve their hypogammaglobulinemia. Any questions on that? It's very common for CLL patients to have hypogammaglobulinemia and need IgG replacement or IVIG replacement, and that can happen every month or every couple of months, and we just serially monitor the IgG levels and supplement them as they continue to be low. Obviously, if they're not low, we skip a dose and keep monitoring, but that can be a chronic requirement for them. And as their disease gets under control, they need less IVIG because their hypogammaglobulinemia gets resolved because their disease is under control. So group 11, along the same lines, the patient asks you about vaccinations. He wants to get the flu shot, and then he asks you about Zostavax. So at this point, based on what you know about the patient and his disease state, what would you tell him about these injections?
Live vaccines aren't recommended for this patient to avoid the vaccine. Avoid.
So avoid which vaccine? Sorry, you broke up a little bit.
Avoid the Zostavax and other live vaccines.
Good. Can he get the flu shot?
Yes.
Yes. So the regular non-live flu shot he can have and should have, and then he should not get the Zostavax because it's a live vaccine. What other vaccination is maybe he potentially eligible for? I didn't give you his vaccine history, but what else do you see as a potential indication given everything I told you about him?
The pneumococcal vaccine, he should get that every 5 years.
Right. So based on his age and his comorbidity of CLL, he is indicated for the pneumonia vaccine every 5 years. So if he didn't ask for it, it would be good to ask him if he's had it or look at his history in the chart and see if he's eligible for that. Great.
Dr. Clemens.
Mm-hmm.
So I didn't think Zostavax was still available anymore since Shingrix is now recommended, and that's not a live vaccine, so would you recommend that?
So if the patient had not had any, previous diagnosis, vaccination, and the Shingrix being a non-live, they can get that vaccination now. Are we actually doing it? I'd have to ask at the cancer center here to find out if they're actually routinely doing that, since that's kind of a new change. But we routinely in the guidelines, it doesn't say they have to get that the way they are recommended to get the pneumococcal. And so I'm wondering, as we move forward with new data, how that's going to change over time. Right now, it's not in the guidelines as a recommendation for these patients, but it also would not technically be contraindicated because it's not a live vaccine. So do we need to give it, or should we give it? I don't think has been answered. Can you give it? Yes. Does that make sense? I didn't want to put it in as required because technically the guidelines for CLL don't say that yet, but they're always being updated. So potentially in 6 months or a year when they do an update, it might pop in there as an option. That's one thing I really like about NCCN, the National Comprehensive Cancer Network, is their guidelines are evidence-based, but they're also consensus-based and experts, and they're updated at least once, if not multiple times per year. And so as new things come out, those recommendations can change quite frequently and really help us get the evidence and new drugs into practice a little faster than a formal, only evidence-based guideline. Like the IDSA only publishes things every so many years. That can get a little bit behind at the times. And so for NCCN, I really like that as a reference. So if you're on rotations in an oncology area, that's something you definitely want to sign up and have access to, because you're going to get more up-to-date what's actually happening in practice than you would looking kind of elsewhere for information. So a little tidbit for the future in case that's helpful to you. I find that to be the best reference to look at what is actually happening nationwide at the premier cancer centers, because they're the ones that come together and make those guidelines. And they give all the citations for why they're saying things, so you can find the primary literature easily to that, rather than doing just a straight PubMed search yourself. You can get straight to what other people are referencing directly from there. Other questions?
I had another question.
Yeah.
So one of your slides said we should test for Hep B if we're considering CD20 therapy. To go along with that, would we want to potentially give a booster or redose a series if the patient could potentially have a low titer for Hep B?
That's a really good question, and off the top of my head, I don't know if I know the answer to what people are doing in practice. It is not routinely commented on or done. So let me look into it, and I can post to ELC about what the answer to that is, because off the top of my head, I don't know. I've not been asked that before, and it hasn't come up in practice. I don't know if I've ever seen a patient get titers specifically. We're just looking for, when we're doing screening, have they been exposed before? We're not actually looking for the lab test that they would do. Like, for example, if you're a new employee somewhere in the healthcare field and they need your vaccine records and you don't have them and they run the titers, that's a different test than when we're looking for having been exposed to Hep B before. There's a different lab test. So we're looking specifically at what's called the Hep B, like core antigen. I'm trying to remember what the acronym stands for. Hep B core antigen and surface antigen, and those aren't the same as the titers we run to see if you have adequate, vaccination history. It's a different test. So I don't know of any patient I've ever had where we've run the test you're talking about. What we're screening for is, have you been exposed before? Do you have the core and surface antigens or antibodies or not? So I don't know if it's ever come up, but I'll look. All right. So case number 4 is a new patient kind of in your specialty retail pharmacy who has a prescription for eye dialysis. So the next couple of questions are a little bit less about patient specifics and a little bit more about drug information. And so group number 9, what are the main counseling points for eye dialysis? And by this I mean, what would you kind of say from in general start to finish to the patient if you had them in front of you or over the phone and you had to do counseling for this new prescription? I'll give you guys a couple minutes if you need it.
So there's black box warnings for hepatotoxicity, diarrhea/colitis, and pneumonitis. So we would counsel them on that. For the diarrhea, we would counsel them to monitor for 6+ stools per day, and if they're in severe pain, any rash or mouth sores, neutropenia. So just tell them monitor for fever, any signs of infection, and anaphylaxis.
Okay, so for the hepatotoxicity and pneumonitis, how would you explain that to a patient? Those are terms they're probably not going to be familiar with. So what would they need to look for or do?
Yellowing of the skin or eyes, jaundice, abdominal pain, and fever, chills, headaches, rash, shortness of breath.
Yeah, so for the pneumonitis, shortness of breath, or any other respiratory complication, difficulty breathing, you can kind of say in different ways depending on how you know your educational level of your patient. But as you counsel someone on oral chemotherapy, you want to be very methodical about how you go through these lists. So I like how you kind of said what the terms so they've heard it, and then you want to tell them what they do about it. So you may have diarrhea or loose stools, which can lead to a significant complication called colitis. If you have more than 6 stools in a day, severe pain, or any blood in the stool, you would need to call your physician or go directly to the emergency room. If you notice any yellowing of the skin, eyes, dark urine, or have abdominal pain, that could be a sign of liver problems called hepatotoxicity. Again, you want to call your physician. Those are the ways to make it more patient-friendly. Everything you said was accurate, but just thinking about how is a patient, we always say in oncology, you want to talk about a 6th or an 8th grade level of patients, unless you know for some reason that they have a higher educational background. That's totally fine to tailor it that way. But just in general, if you're cold calling, talking to somebody who's just walking up to you, the expectation you should have is that they don't know these terms. And then anaphylaxis, that's a term some people would know, but not everyone. So if you have difficulty breathing, you feel like your throat's closing, you're unable to catch breath, you have any kind of hives or things like that, just being able to explain it to someone, what will they see and what do they need to do about it? Framing it in that way is necessary. Also, when you're counseling on oral chemotherapy, they also need to know some just general information, right? It's great to know, here's what you may experience and here's what you do about it for the side effects, but also just in general, how are they going to take it? What is it doing in general? and any issues that they should have around it. So, for example, for the idelalisib, this is an oral chemotherapy drug that you take once a day, right? It is what's called a PI3 kinase inhibitor, so it's going to inhibit the overactivation of your cancer cells in a very specific way. You don't have to tell them exactly the clinical mechanism, that might not be necessary, but just so they know what it does. And maybe this patient has or has not had cytotoxic chemo before. So putting it in perspective to what they've had before, I always, before I counsel a patient, look at what they've had. It tells me how knowledgeable they are about their disease and condition, because if they're a new diagnosis starting something, they're probably very overwhelmed to begin with. They may not know anything, versus this patient's had 3 or 4 lines of chemo. They might be a little bit more savvy with terminology and side effects and what to expect. And so you can kind of tailor it based on their history as well. And so if they've had, intensive IV chemo, cytotoxic before, also comparing and contrasting what they've experienced before to what they'll experience now, because oral chemo has different types of side effects than we've seen with the cytotoxic chemo, what to expect. So it can help to kind of just put them in a frame of reference, as well as put yourself in a frame of reference of where is this patient coming from, how knowledgeable do I think they are based on their cancer history as well as potential educational history, which you can get out of the charter. Sometimes I'll ask the patient before I go to room and counsel, what's this patient like, and they'll say, they're highly educated, you can definitely talk to them at a high level, and maybe they have a doctorate, or I've had several physicians as patients before, versus, they don't even have a high school education, so make sure you're using very patient-friendly terms and ensuring that they understand what you're saying. So definitely tailor it to your patient. Yes, ma'am.
On the slide, it says that it's taken twice daily, so is it once or twice?
It's twice daily. I'm sorry, I was thinking about it, I wrote it in my head when I said that. So idelalisib is twice daily. Thank you for correcting me. I just definitely missed it there. The other thing about this drug is how is it taken specifically? Yes, I said orally, but what else about it would you need to tell a patient that's important for oral chemo, especially making safe handling things? I heard a couple people here say you can't crush it, right? And so it says to swallow whole, so they should not be manipulating that at all. They shouldn't have a family member be manipulating it at home. And then the other thing about oral chemo is can they take it with or without food? So we talked a lot about PPIs and H2 blockers and with other drugs, but some drugs it's not about the pH, but it is about whether they can have food or not, and whether that's going to affect absorption. So making sure you're double checking how your patient's taking it and know how to take it. Those specific instructions again lead to efficacy. If they take it incorrectly, it might not work as well. So thankfully for this drug, it doesn't matter with or without food. So you can put a patient's mind at ease. But for others, if they have specific instructions, you want to make sure you tell them that so they're taking it accurately so that it can work fully. So what does it do? How is it taken with any comments? And then what to expect with the side effects, making sure it's in patient-friendly terms. That's how you kind of would need to frame this verbally to a patient. And a lot of times these are over the phone, so if you're working in retail pharmacies or specialty pharmacies, these patients may not be near you or in your same state, you're filling and mailing them out, but you have to do this over the phone as a requirement for the specialty pharmacies to talk to patients and to look at the lab before they dispense things. And so you may have to do this over the phone, which can be a little bit more challenging because you don't have those patient visual cues of do they look confused, are they nodding long, are they trying to interject to say something. So over the phone can be a little bit more challenging, but as you do more of them, you kind of get your own style and get used to it. But in person is a little easier to kind of adjust as you go along to what the patient needs. So I always prefer over in person than over the phone, but that's not always possible depending on your work setting. Yes.
Because of the anaphylaxis, do we give these patients EpiPens, or do we just tell them to call 911?
So, to my knowledge, I don't think anyone is dispensing that preemptively. The incidence of anaphylaxis with these drugs that I'm aware of is extremely small. I've, knock on wood, never seen it either. But yes, knowing the signs and symptoms is what we want to counsel them on so that they know to call 911 immediately and say that they've just taken a new medication or their caregiver around them would say that. But it's not something that we supervise the first dose in clinic or anything like that. And I would have to go back to the primary literature to see if it's after the first dose or just after a few doses that they develop a reaction. I don't know the timeline for that because I've never seen it, and it's such a small incidence. I would assume, and I'm not 100%, that it's after a few doses, so one of those developed reactions. But we still want to make sure they know what to look for and the fact that that's severe, right? So some side effects are, hey, just call your doctor in summer. You need to call 911 to go to the ER. Delineating that for a patient is extremely important. Like fevers aren't call the doctor and wait a day. No, you can call them, but you need to go to the ER. signs and symptoms of anaphylaxis are also, probably doctors looking you to go to the ER. But thankfully, I haven't seen it, so I hope I don't. Good. Other questions? Okay, group 17, we're going to talk a little bit about being, you're in the clinic, you're the staff pharmacist in the infusion area, and you're asked by the nurse to counsel a patient who's about to start the drug alemtuzumab. So this is a CLL patient receiving the first dose of this monoclonal antibody. So let's tell us a little bit about how the drug works and specifically what's its target.
It's a CD52 monoclonal antibody. It's a CD52 monoclonal antibody. It targets the CD52 on lymphocytes, and it activates complement and the antibody-dependent cell cytotoxicity.
Good. So it has as a monoclonal, it has multiple of those mechanisms. Remember, monoclonals may or may not have multiple targets or mechanisms. So this lyses the lymphocytes not only through the complement fixation and the antibody-dependent cell-mediated toxicity, but also there's some direct signaling for apoptosis as well. So it does all three of the mechanisms. And as you correctly identified, alemtuzumab targets CD52. And so that's on B cells, but also some other immune cells. So that is why, as we're about to talk about, some of the toxicities are a little more broad than what we see on the CD20 B cell targeted therapies. This has targets on other immune cells, so we see a little bit broader of side effects. So what are those side effects I'm alluding to?
They'll have some infusion-related events, and then myelosuppression like thrombocytopenia and neutropenia, and then they're at an increased chance of infection, so they're most likely going to receive some prophylaxis against viral, bacterial, and/or fungal.
Right, so the infection, the reduced immunity is because CD52 is expressed not just on B cells. There are some other immune cells that also co-express that marker, and so that's why these patients are at higher risk of infection. It's not just that we're targeting the B cells, we have some off-target effects as well, and that increases their infection risk because they're more immunocompromised. So because of that, patients on alemtuzumab have to be counseled for the signs and symptoms of infection specifically. And so the most important thing, again, for that is telling them if they have a fever, they need to go to the emergency room. We tell our patients they can call the cancer center line to let them know that they're coming to the ER. A lot of times we'll just try to direct them to the floor and bypass the ER, but they still need to come immediately if they're having fevers. They also need to know just the general signs and symptoms of infections to be aware of. So things like chills, cough, abdominal pain. If they have an IV line, the cellulitis, what does that look like or feel like if they have, a port or a pick or something like that. The other thing, because it's a monoclonal that you correctly identified, is infusion reactions are pretty much possible with any monoclonal antibody. It's universal because it is an infusion of a monoclonal antibody, so that's a potential issue as well. So for this specific drug, group 17, does the patient need screened for Hep B? Why or why not?
We said no because it doesn't target CD20.
Right, so only the CD20 monoclonal antibodies have a requirement to be screened for the Hep B beforehand. So if you have a patient getting rituximab, ofatumumab, bevacizumab, those drugs do all require Hep B screening beforehand. Alemtuzumab does not. So just because it's a monoclonal isn't the point, it's what it's targeting that matters. And then lastly, you alluded to the fact that the infection risk is through the mechanism and the patients do need some prophylaxis. So tell us a little bit more about that.
We just tell them to monitor for signs of infection like fever, and they get their blood counts monitored, and then we give them prophylaxis with probably acyclovir and Bactrim for at least 2 months after they completed therapy.
Good, so they need the antiviral and the anti-PJP prophylaxis during therapy and for 2 months after, because it takes time for those cells to reconstitute the drug that's inhibiting them, and you have to make more cells that aren't inhibited. So that's why a 2-month post period is there. So acyclovir and Bactrim are the most common. Obviously, there's some alternatives for PJP prophylaxis. I wouldn't test you on that for this exam, but just be aware. You use things like Dexone and Tocopherol, or even inhaled or IV contaminating are options. But typically, we try to, if patients don't have an allergy or an intolerance, do the Bactrim first. And then what other reactivation is possible that we don't get prophylaxis for, but a patient would need monitoring of?
CMV?
Yeah, so cytomegalovirus can reactivate these patients, again, because of the profound immunocompromised state. And that's something that in this particular indication, we monitor lab tests for, and we would only give them treatment of reactivation if it occurred, but it's something they'll need lab monitoring of at set intervals. So antiviral prophylaxis with acyclovir, anti-PJP prophylaxis with Bactrim, and lab monitoring for CMV, as well as good counseling of febrile neutropenia and finding an infection, are all necessary for patients on alemtuzumab, and that's because it targets CD52 not only on the B cells but other immune cells as well. Any questions on either of these drugs or counseling points?
I have a question in Athens. Why would you not screen for hepatitis B when alemtuzumab does have the ability to cause reactivation of Hep B viral infection?
So alemtuzumab does not cause Hep B reactivation. We don't see that commonly just based on the drug's mechanism, whereas your anti-CD20 monoclonals, the clinical data for all of those, which are rituximab, ofatumumab, and obinutuzumab, those three drugs, the data did show a reactivation of Hep B at enough of an incidence in the clinical trials where they wanted all patients to be screened up front for, but for alemtuzumab, based on its different mechanism, we didn't see that in the clinical trials, so we don't have to screen patients beforehand.
I'm sorry, but do you mind, can we touch the prophylaxis again?
You broke up a little bit. Were you asking me to repeat the prophylaxis, or I just want to make sure I heard you?
Yes, ma'am. Just to repeat it.
No problem. So for alemtuzumab, you want to monitor the lab test for cytomegalovirus reactivation. So that's just so you're aware, it's a PCR test to look for how much of the viral load is in the blood. You obviously want it to be 0. If it got to a high enough level, they would give treatment for CMV. We're not going to talk about that today, so I would not put that on the exam. But knowing that they need to be screened for CMV serially is important. And then they need prophylaxis with the antiviral agent acyclovir, so that covers your HSV and VZV reactivation. And then they need anti-PJP, formerly called PCP, prophylaxis, typically with Bactrim. There are some alternatives. Again, what would be alternatives on the exams? That's not the focus of this content here. I just want you to be aware of it. Other questions? Okay, so the last case today is CC, who's a 63-year-old male with CLL, originally diagnosed in 2010, received 4 cycles of the chemotherapy regimen FCR, followed by 2 cycles of VR, and he had prolonged neutropenia at that time. So he was switched to receive weekly rituximab, and he received that for about 7 months. He was started on ibrutinib, but was non-compliant, and subsequently his repeat workup showed that he has the 17p deletion, which he did not have initially. So as his disease progressed, he gained the mutation. Currently, his workup, he does have lymphadenopathy. You see he has a high white blood cell count of 35. His absolute lymphocyte count is 29. I put his chemistries here, so his creatinine is a little bit up at 1.1, baseline of 0.9. And his blood glucose is normal, uric acid is normal, and LDH is elevated. Again, LDH being a fairly non-specific marker of tumor burden. The physician wants to start venetoclax therapy, which I'm telling you at this point is appropriate, because the goal here is more about supportive care and things. And so, group number 12, let's talk about this patient. And so what are the main adverse events from venetoclax? And again, how would you kind of counsel a patient? What would you say about these in more patient-friendly terms?
Tumor lysis syndrome and neutropenia, thrombocytopenia, nausea, diarrhea, and fatigue.
Okay, so that's definitely a comprehensive list of the most important side effects from venetoclax. How would you explain these to a patient? I mean, fatigue is easy, right? So you may feel more fatigued. That's an easy one. But what else?
I guess we would just tell them that it might upset their stomach and that they might be experiencing some kind of weakness or bleeding due to decreased clotting and just decreased blood factors.
Yeah, so saying you may have low blood counts, which includes lower hemoglobin, which can cause anemia, and that means you may feel more fatigued. And you also may have low platelet counts, and that's the part of your blood that makes you clot when you cut yourself. And so those low platelets called thrombocytopenia can increase your risk for bruising and bleeding. So you want to let your doctor know if you notice extensive bruises or if you have bleeding that won't stop you from going to the emergency room. So those are kind of ways to explain that to a patient. The GI, I agree, just saying it may upset your stomach, cause some nausea. You may have some loose stools if those are severe or impacting your quality of life. Let your doctor know there's medicine we could give. You know, that kind of thing would be fine to say. But what about tumor lysis syndrome? How would you explain that to a patient? I know you guys had a whole session on TLS, but I doubt it was focused on how to counsel a patient because most of that happens in the hospital and we're doing it ourselves. But in this case, it's happening potentially in the community setting. So how would we tell a patient what to look for, what it is, what to expect?
I'm not sure, but would it be like joint pain potentially, or just malaise from uric acid?
So high uric acid typically is fairly asymptomatic. The other electrolyte abnormalities are more likely to cause the clinical signs and symptoms. So usually patients don't know they have a high uric acid. I haven't seen anyone complain of joint pain. I know obviously with gout, if you have, potentially uric acid level may or may not be associated. I've had plenty of patients with gout pain, uric acid levels are normal. So the level doesn't necessarily correlate with the pain in that disease state, but I see where you're coming from when you would think that. But thinking in tumor lysis, what are the other electrolytes that are involved? And this is for everybody, just as a refresher, because it's really important. You're going to see it in a lot of sessions.
Potassium.
So I heard you're going to gust of potassium. So high potassium leads to what complications?
Heart.
Cardiac, right? So a patient may notice heart palpitations. Obviously, we on the signs would have an EKG that would show problems. So high potassium is possible, so they may have some notice of heart palpitations. What else?
Calcium.
So calcium, the calcium goes up or down?
Down.
Down, right? So hypocalcemia. And along with that, what goes up? The phos, so hyperphosphatemia. So what are the signs and symptoms of hyperphos and hypocalcemia?
Cramp.
So tetany and cramps are from the calcium, so that is definitely a possibility. I talk to patients about twitching, and they notice muscle twitching or cramping. So that's the way I explain it to a patient. And then remember that they can have the calcium phos precipitate in the kidneys, and then the uric acid that can damage the kidneys. So the renal failure, a patient isn't going to know because they don't have the lab values, but what might they notice physically if they were going into renal failure?
Stop peeing.
Right, they may stop peeing or have a reduced urine output or a darker urine. So those are things they could look for, is how much are they urinating, how dark is it, what's the volume and frequency of the urination. So that is something that definitely can keep track of. Anything else?
Altered mental status and seizures and stuff.
Yeah, so altered mental status and seizures from the electrolyte changes acutely, the brain fluid balance that gets off. So they could have that in severe clinical TLS. So those are the kind of things you would want to explain to the patient. And how I go about explaining it to a patient is this medication is going to kill off the cancer cells, and it does so fairly rapidly to start. So because the drug is working very effectively quickly, you have a lot of cells dying off. And all the normal components of your inside your cell are going to be out in the bloodstream now. So your body has to handle all of those components very quickly, and sometimes that can damage some organs. And so the things we want you to look for are any cramping of your muscles or any twitching of your muscles. We want you to look at your urine output. So are you peeing normally? Is your urine darker than normal? Are you peeing less than normal? Are you all of a sudden not peeing at all? Those are things we want to know about. And then if they notice any kind of abnormal rhythms or heartbeats, that would be something else to report. So that's the way I kind of explain it to a patient. And obviously we're checking the labs and we may be running tests and all of that. But what can they expect or what should they report? Some patients have things happen and they're like, oh yeah, all night this was going on. They're just now telling us. But if they know you want them to report it, it can really help. So that's how I would kind of counsel a patient on TLS. Any questions on venetoclax side effects? Other than ibrutinib, venetoclax is probably the #1 oral chemotherapy drug in heme malignancies that is being prescribed right now. Both ibrutinib and venetoclax have gained multiple indications very quickly, and they're even being used off-label a lot. Obviously, not going to touch on any of that. But I want you to know that these two drugs are being used, they're being investigated in a lot of malignancies. I anticipate in a year or two, when you're out in practice, that these drugs are going to have more indications and be used much more widely, and so we're going to have a lot more patients on these. They just happen to be very effective therapies that the data is pretty strong for. So they started out kind of with one indication and it's really rapidly growing. So by the time you're done with this exam and out in practice, it's going to be different. So I just want to highlight that these two drugs in my practice, we're calling it vitamin B because we're using it for like everything off-label right now. So it's definitely gaining a lot of traction because it is very efficacious. And the nice thing about it is it works pretty quickly. And a lot of these other therapies don't. They take time and multiple cycles to see a response. So while it works quickly and that's beneficial, the downside to that is the TLS, right? So it's a trade-off, the efficacy and the safety you have to balance. So group 3, thinking about this, because TLS is one of the most important side effects of venetoclax to be aware of. Think about this patient specifically with the data I've given you. How would this patient be started on venetoclax? Specifically tell me the dose duration and very importantly what supportive care is warranted based on this.
So they're going to be on a titration schedule to increase up to 400 milligrams by mouth every day as maintenance therapy. So you're going to start with 20 milligrams by mouth every day and increase in weekly increments up to 50 milligrams, 100, 200, and then finally at the 400 milligrams every day, which will be the maintenance dose. And for supportive care, since this is considered a high-risk medication for TLS, they're going to be inpatient and get 1.5 to 2 liters of oral hydration and 150 to 200 mLs per hour of IV hydration as they tolerate it. And then they should get allopurinol, so the first dose will be 20 milligrams and 50 milligrams, and then pre-dose at 4, 8, 12, and 24 hours.
Excellent. So it is definitely a titrated drug every week, and depending on the risk factor for TLS, whether they're low, intermediate, or high, we have different interventions to prevent TLS. So why was this patient high risk specifically? What was the factor that made you determine that?
Does it have to do with their uric acid 5.1?
So it actually does not. That would help us delineate whether we needed to give the patient preemptive uricase or not. But specifically categorizing the patient for the risk of TLS to begin with into what strata of low, intermediate, or high we would do is based on something else. There's two specific things there. Anybody know what those two things are?
The lymph node size and then their absolute lymphocyte count.
Right.
LN and ALC?
Good. Their absolute lymphocyte count or their ALC and then their lymph node size. So this patient actually met both criteria, just happened to. So their largest lymph node was 7 centimeters, so that's above 5. And their absolute lymphocyte count I gave you as 29, which is above the 25. So this patient met both. You could meet either, or you have to meet the lymph node above 10 or lymph node above 5 and lymphocyte count above 25 to meet that. So there's either one thing or both combined that makes you high risk. So if this patient had a low lymph node size and lymphocyte count, they would be low risk and we would be doing different things. On the exam, I will either give you the table of low, intermediate, and high. That first column tells you the tumor burden. I don't expect you to memorize that. Or I will tell you whether their tumor burden is low, intermediate, high, one or the other. What you need to know is if they're low or high, what you do about it. I will tell you which one they are, because that's something you can always look up, you don't need to memorize, but knowing what intervention to make based on their risk is something I do want you to know. So in the slide, there's a nice table I cut and pasted. So that first column information will be provided to you, but what to do about it is what I want you to know. And again, this is really important as we risk stratify patients, what interventions do they need? And it's a major difference, right? Our low-risk patients only need oral hydration and allopurinol, and they can be treated in an outpatient setting. They don't need to be admitted to the hospital for these doses. Now, they still need lab work, but they can do this in the clinic and then go home. Versus your high-risk patients, right? They're in the hospital for these first doses of the 20 and 50 milligram to be monitored. So they get their lab work, their IV hydration, maybe RAS uricase if their labs warrant it. So that's where that uric acid level does come into play. Obviously, any patient, whether they're low, intermediate, or high, if on their lab work at whatever hour, the 8-hour, the 24-hour, whatever mark, they meet the criteria to receive RAS uricase, we would give it then as treatment. That is definitely indicated. What the guidelines are talking about is high-risk patients who come in with a high uric acid can get preemptive RAS uricase. That wouldn't happen in your low risk because low risk shouldn't have a high uric acid. It wouldn't be low risk if that were the case. So again, low risk, outpatient, oral hydration, allopurinol, just get the lab monitoring, get to go home. High risk, they get the oral hydration and allopurinol, as well as continuous maintenance IV fluids at a fairly high rate. We see 150 an hour. Multiply that at 24 hours, that's a lot of fluid, right? We would adjust that in like a heart failure patient if there was a specific reason, but as long as they can tolerate it, that's what's recommended. And those patients are admitted to the hospital for the monitoring and the lab work because they're anticipated to go into tumor lysis. Remember, the more tumor bulk you have, the more lysis you have, the less your body can handle it. Your kidneys are not equipped to deal with all of those intracellular contents all at once. So those patients are admitted for close monitoring, and typically at those 4, 8, 12-hour lab marks, we're making interventions for active TLS. The patients I've seen, if they don't come in with TLS already from their disease, they are at one of those markers having hyperphosphatemia, hyperkalemia, hyperuricemia, and we're having to do exactly what you guys learned in your previous session, giving them things like K-exolate and calcium, giving them phos binders, potentially giving them RAS uricase if they need it, making sure they're keeping up with that oral hydration and their maintenance IV fluids are going. So those patients, the ones that we have seen with high risk, do go into TLS, so that's why it's appropriate for them to be in the hospital. Because if you waited 24 hours to check their labs, they would be in clinical pulmonary and probable organ failure. So you want to check it at the 4, 8, 12-hour mark and really get a jump on managing the laboratory TLS to prevent the clinical from happening. And as you can see, this drug works very quickly, very effectively. At 4, 8 hours after the first dose, you're in TLS. That's pretty impressive. You don't see that with a lot of other therapies. With our IV cytotoxic chemo, yes, over a day or so you can get TLS, but it tends to be pretty rapid and pretty intense with the high-risk patients. So the higher your tumor burden, the more likely you're going to get TLS. Pathophysiologically makes a lot of sense. And then other things about the supportive care needed is for this patient just, I didn't give you more of his background about comorbidities and other drug therapies, but when the patient is being screened for venetoclax therapy, you would want to do a drug interaction check, right? So always as a pharmacist, you want to make sure that the drugs we're providing are safe and effective. So the safety check is to look for drug interactions. Anyone know what the interaction category CYP is for venetoclax?
3A4.
Yep, so 3A4 strong inhibitors are to be avoided. Moderate inducers, as well as our PGP inducers and inhibitors, are something to be considerate of. I'm not going to test you on this, but the product labeling does have dose adjustments that are recommended depending on what interaction they're on. I'm not going to test you on doses. I feel like that's something you can always look up and advise physicians on as we go forward. But I want you to be aware that a lot of these patients are on CYP inducers and inhibitors, and we do have to do dose adjustments. So you're not going to see everyone on this nice titration. They're on a different titration if they have drug interactions. So you may see prescriptions for different things. Just double check the product labeling and their drug interactions and make sure that that's appropriate. Unfortunately, I have seen several patients, and this is boggles my mind that this happens a lot, who are prescribed the normal venetoclax. It goes to a specialty pharmacy because that's what their insurance requires. They're dispensed the product, and then they come in, and then we see it because they are put on the schedule to start it. We look at them in their labs, and then we say, hey, they're on these other drugs that interact. This is not appropriate. So because sometimes the specialty pharmacy is separate from our system, I might not be there when they prescribe it and send it and get it approved. I'm only on the back end when the patient is on the schedule and comes in, so I'm catching the error late. If the patient started in an ambulatory care setting, they may have already started it wrong. But if they're coming in for inpatient, then I have a problem, right? So they're about to start a drug that's the wrong dose. So they have this nice dose pack that's dispensed by the drug company that's all wrong. The drug company's done it very well. You can look at the venetoclax website from the company. They have a nice color-coded weekly titration, like punch packet thing that comes in a box for the patient. So it's like week 1, do this, week 2, do this, week 3, do this. So it visually gives them cues and is very good and patient-friendly. But the problem is you can't really manipulate that for some of the dose adjustments that are recommended. It's a practical thing I just want you to be aware of. So sometimes these specialty pharmacies are disjointed from the system of the patient, and fixing that problem on the back end is very problematic because the patient now can't fill a new box of a new titration or get the pills that they need because their insurance is going to pay for it for a month because they've already got one supply. But it's the wrong supply that I can't manipulate for the new titration schedule because again, you can't keep breaking and doing things with these. So it can be somewhat complicated. So if you are the pharmacist at any point in this process, you need to be thinking about what are the other medications the patient's on, what are their comorbidities. If you don't know, you need to find out that information. You can't just blindly be filling these because the insurance approved it and shipping it out or sending it to the patient. You have to be comprehensive about it because it can lead to significant problems and delays for a patient starting appropriate therapy. And in cancer care, that's not good. You don't want to wait a whole month to start therapy or wait a week or 2 to figure out how to get to override and redispense the right tablet sizes, or worse, have to change their other therapy that they were stable on so that they can get this drug at the dose they do have. I've had a lot of logistical complications with this drug, so that's why I'm harping on the fact that we all need to do a good job of touching these patients, of being comprehensive and making sure it's the right thing. The general label dosing isn't always what the patient needs to get, so you have to think outside the box and be more comprehensive with your assessment. And the patients, I've had patients start the normal titration and go into more TLS and have more side effects and problems because they were on the wrong dose and we caught it after the fact. You know, that's not a good error to have chemotherapy or any drug on a patient. And so please do your drug interaction checks and be mindful of making sure the physicians are doing the appropriate thing. And I've had doctors, right or wrong, they say, I just prescribe it and I expect you to fix it and tell me what to do. So they have this mindset that we're their safety net. They have this mindset that we know these things and we'll fix it. That may not be appropriate, but it's the way it's working. So I really want you to really feel like you have the ownership over helping them make sure the drug is the right thing. So again, I've just seen this error several times and it's very frustrating. Any questions about venetoclax? Again, definitely knowing, depending on a patient's risk stratification, I would tell you what we knew. You know, are they inpatient, outpatient? Do they get IV hydration or not? I'm not going to pick an intermediate one and make you decide. That's clinical judgment. As you see, you can admit them or not. I wouldn't put you in that scenario. I'm going to be very clear about which the patient is, and then you would have to know what to do about it. But knowing that the TLS information here is very important. So overall, I hope these cases have shown you that for CLL, there are a lot of different therapy options. Which patients get which ones and in what order is a little bit beyond the scope of this class, but knowing if a patient's on a certain therapy, what does it target, you know, what's its mechanism, what are the main drug interactions and dosing considerations. Again, I'm not going to test you on actual doses at 170 milligrams a day. You can always look that up, but you know, is it an oral drug or an IV or a sub-Q drug? You know, how, in general, what are the dosing things the patient would need to know? And then what are the main side effects and severe side effects? And if we talked about managing any particular side effect like TLS, knowing what that would be, that's very important. Along with some of the basics, obviously, about the disease itself. There's always, again, some background questions I ask, so you've seen that in my other sessions. And then for chronic myeloid leukemia, what are the initial and subsequent second and third line treatments? Again, what are their dosing considerations, drug interactions, main side effects and considerations. If I gave you a patient with some comorbidities or other drugs, the expectation from the other classes that you've had is that you would know which things to avoid based on those interactions and those disease interactions, like we did in the cases today. Any questions on either CML or CLL? All right. Well, we're done just a smidge early. I'm the IPC person today, so we're going to meet back here at 12:10 when Albany's back online so they can participate. So I will see you all shortly. I have posted, I forgot to say, I apologize for saying at the beginning of class. I did post the lymphoma slides. I apologize, they were in draft mode and I forgot to undraft them when the lecture was posted. So that was my fault for Monday. So those are up there, not just the lectures. The rest of it is there. And thank you to the person who pointed out to me that they weren't there. So I apologize for that delay. That was unintentional. And the DMT lecture for next week should be posted later today. I'm waiting on the recording to be sent to me so I can put it on ELC. So that is also, the slides are up and the lecture should be up shortly. As soon as I get it, I will post it for you all. And so those things are available for you to prepare for next week as well. Thank you.